Dr. Muzny and Dr. Van Gerwen to the lecture today. They're going to provide an update on vaginitis, BV, and trich and vulvar candidiasis. I think many of you all have read, at least through internal announcements, that both physicians have actually opened up a vaginitis clinic at Highland, so we're really excited about that. And actually, I've been having ongoing discussions about how we can further collaborate with Dr. Van Gerwen and Dr. Muzny. So first off, very quickly, Dr. Muzny is an associate professor. She's in the Division of Infectious Diseases. If I'm not mistaken, I think you did your training in Mississippi, and you've been here for a while. And importantly, she serves as a vice chair for the IRB here at UAB. And then very briefly, Dr. Van Gerwen is also in the Division of Infectious Diseases in the Department of Medicine as an assistant professor, did her residency at Tulane and did her ID fellowship here at UAB, and also has a very strong interest in vaginitis as well. So I'm really super excited to introduce both of them to the CWRH seminar series, and I'll hand it off to you guys. Thank you.
Thank you so much for that introduction. Can everybody hear me?
Yep.
Okay, great. So I was going to do the first half of the talk today to talk about the 2021 CDC STD treatment guideline updates. And then Dr. Van Gerwen is going to talk about a few patient cases that we are currently working with in vaginitis clinic. And she'll tell you all a little bit about the clinic. And we really appreciate the opportunity to be here today and to talk about this. I'm going to advance these slides. Sorry. So I have several disclosures that I wanted to list in this presentation. I think for the purpose of the talk today, the most important one is that I was a consultant to the CDC for working on the 2021 guidelines. So as part of that, I wrote several sections of the guidelines, but I also edited other sections of the guidelines. So I just wanted to disclose that today. And Dr. Van Gerwen.
Yeah, and I do some work with a couple of pharmaceutical companies for research grants, and then also I'm on a few different NIAID grants as well.
So the learning objectives today, I wanted to provide a few updates in epidemiology, diagnosis, and management of the vaginal infections, BV, Trichomoniasis, and Vulvovaginal Candidiasis. And then, as I mentioned, Dr. Van Gerwen is going to talk about a few cases, complicated cases that we're working with at our clinic. So I just want to start off, this is pre-COVID, so no mask. This is everybody that worked on the CDC STD treatment guidelines. And we had an in-person meeting of the experts in Atlanta, Georgia, 2.5 years ago now, where we all got to take this picture together. So this was my first time working on national guidelines. It was a very rigorous, exciting, terrifying process. And the guidelines were actually supposed to come out in 2020, but because of COVID, there were significant delays and they got published in 2021. So with regards to these 3 vaginal infections, the first one I was going to talk about is BV. And I'm basically just going to give you a couple of brief updates. So there was a recent paper published in 2019 updating the global burden of BV prevalence data. And the investigators at the University of Washington that did this study found that in North America, the overall BV prevalence is at 27% among women and ranging between 24 to 31%. Similar to other sexually transmitted infections, there's a significant racial disparity with regards to BV, with African-American women having the highest prevalence. There's been more and more epidemiological data that suggests that BV is a sexually transmitted infection. We talk about this a little bit more in the guidelines, and we'll talk about it in the background BV paper that will come out later this year. With regards to the guidelines. And I have several of that data listed on a couple of these slides. So BV is known to be associated with inconsistent condom use and increased numbers of recent and lifetime sex partners. Women with BV have an earlier median age of sexual debut than women without. The most significant risk factor in multiple studies for a new case of BV is a new sexual partner, while that for recurrent BV is a regular sexual partner. And there's a high level of BV concordance in women and their female sexual partners. Also, there's been additional data, next generation sequencing studies looking at BV-associated bacteria in the men and looking at their penile microbiota. So they found with men having community state types that are associated with BV-associated bacteria were more significantly likely to have a female partner with a higher Nugent score. And the penile microbiota of male partners is significantly more similar to the vaginal microbiota of their female partners. And they also have found that detection of PSA among women is positively associated with BV recurrence. Partner concurrency is also significantly associated with prevalent BV. And among women who have sex with women with a new case of BV versus those without, one of our studies found that the relative rate of any sex prior to incident BV was 40% higher, digital vaginal sex almost 60% higher, and digital anal sex 5.6 times higher. And in a systematic review of male circumcision, STIs, and BV, male circumcision was found to result in a lower BV prevalence in women. So with regards to updates in BV diagnostics, we all know about the traditional diagnosis of BV with the AMSEL criteria and the Nugent score. But there has been an advance in BV molecular diagnostics over the past several years that are now mentioned in the updated CDC guidelines. And these tests are nucleic acid amplification tests that are much more highly sensitive and specific than the AMSEL criteria. The main caveat about these tests, though, is that they're only FDA approved right now to use in symptomatic women. So they're not to be used in asymptomatic women, but they are objective. They're able to detect fastidious BV-associated bacteria. They enable quantitation and are ideal for self-collected vaginal swabs. So very good for symptomatic women in clinical situations, especially when microscopy is not available. You can't do a wet mount and situations such as that. So interestingly, it's a little controversial about what organisms need to be included in these BV molecular diagnostic tests. And so there's actually 5 of them available in the United States right now. I think the next slide that I have summarizes all 5 of them, but only 2 of them are FDA approved and the other 3 are laboratory developed tests. So they have to be internally validated by the institution prior to using in patient care. And they all are a little different in what they're detecting. And it all kind of leads to the fact that we still don't know exactly what causes BV, the inciting organism or organisms. That's still controversial. And so because of that, we still have controversial diagnostic tests and treatment. However, some of the bacteria most commonly seen in some of these BV diagnostic assays are going to be Gardnerella vaginalis, Adipovium species, Megasphaera type 1, and BVAB2, because these are found to be more highly sensitive and specific. However, you can see on here, Gardnerella, the specificity is actually not that great, but as many of you know, the majority of BV research has centered around Gardnerella vaginalis, and it can be found in between 95 to 100% of cases. However, it can be found in women who are just colonized, in contrast to women who have symptomatic BV. Nevertheless, Gardnerella is still a very common BV-associated bacteria, and it's included in many of these molecular diagnostic tests. So this is the slide where I have summarized all 5 of these tests. The 2 that are FDA approved right now are the BD Max vaginal panel and the Hologic Aptima BV. The other 3, as I mentioned, are laboratory developed tests. And based on the certain tests, you get a different result. Some tests give you qualitative results, positive or negative for BV. Others will give you scores. It just depends on the test that you're running. But remember, again, you would only want to use these tests in symptomatic women. With regards to treatment in the CDC guidelines, when we were working on this section, we found 3 new single-dose BV medications that are now FDA approved and available in the United States. The first one is a single dose of Clendes 2.2% intravaginal cream. This was actually FDA approved many years ago in 2004, but it was not commercially available in the United States until recently, so it hadn't been in prior CDC guidelines. We did add it to the new guidelines. There's also a higher dose of metronidazole intravaginal gel at 1.3% single dose that was FDA approved in 2014. And most recently, we had oral signatazole FDA approved in 2017 for BV. And this is a next generation 5-nitroimidazole medication that's in the same class as metronidazole and tinidazole, but it has a much longer half-life than those other medications. So it has been FDA approved as a single dose treatment oral for BV. It does have a little quirk to it in that it's an oral granule formulation. And so you have to dissolve the granules in pudding, applesauce, or yogurt and mix that up and then eat the little serving of whichever one of those 3 that you're taking it with. So it has a little quirk that patients need to be counseled on about administration of that medication. However, we did not find any data suggesting superior efficacy of these newer medications to currently recommended BV therapies. So here are the 2021 recommendations for BV and the guidelines. The currently recommended regimen box did not change. The oral multi-dose metronidazole or the Metro Gel 0.75% or clindamycin vaginal cream are still the recommended regimens. However, we did add oral signatazole to the alternative regimens box. And you may be asking, well, why is signatazole not in the recommended regimen box? Especially if it's a single dose, and none of these other medications are single dose. And there were several reasons for that. We actually had a vigorous debate at the guideline meeting about that. One issue is that signatazole is much more expensive than oral metronidazole, which I have a cost table coming up. The other thing is that it has not been studied head-to-head with regards to multi-dose metronidazole. The signatazole BV studies were placebo-controlled trials required by the FDA, so we don't have head-to-head data comparing it directly to metronidazole. And also, we just don't have as much clinical experience using signatazole in BV patients as we do with metronidazole, which we've been using for decades now. So a lot of that was some of the reasoning why signatazole got added to the alternative box and not the recommended box. In the paper that we're going to publish later this year, the background paper for the BV section, I did a cost summary of all of these treatments. I'm not going to read this whole chart out to you because it's very detailed and dense, but in black are the current recommended therapies, in blue are the alternative, and then in red are these 3 new single dose therapies. So basically, you can see down here at the bottom that oral signatazole is $272. I mentioned it has a much higher cost. The company that makes it, Lupin Pharmaceuticals, does have a patient drug assistance program where any patient can get it for $25 with some paperwork provided. And then for people who are below the poverty level, they can get it for free, but this does require some paperwork and is definitely not as cheap as multi-dose oral metronidazole, which is $7.80. And, this is more cost effective to use, especially in public health clinics where we give directly observed therapy and we dispense medications. The last thing I'm going to say about updates in BV, it's not currently recommended to treat male sexual partners of women with BV or female sexual partners. And this was in the 2015 guidelines, and it's still in the 2021 guidelines, even though, as I mentioned earlier, there is a large body of epidemiological data suggesting that BV is an STI. And sadly, we're not treating partners right now, mainly because of prior male partner treatment trials that were conducted in the 1980s and 1990s, which I have summarized on the slide here. There's actually 6 trials that were done. All of these trials were done in a time where men were getting single dose 2-gram stat dose metronidazole, and women were also getting that. They were not getting multi-dose metronidazole back then, which we know now is an inferior regimen for women with BV. So we've always thought that that's one of the main limitations of these partner trials, because the wrong dose was used back then. They just didn't know back then. The other issues with these trials, they were not methodologically rigorous in today's standards. Male partners were not physically enrolled in many of these trials. The females were just given the medicine, like expedited partner therapy, to hand to their male partners. And so a lot of these trials don't have adherence data from the men, and they don't know for sure if the men actually even took the drugs. But the large majority of these trials did not show a significant benefit from treating male partners, which is why it's not currently recommended. However, my colleague Jane Schwepke here at UAB, who has recently retired last year, did a male partner treatment trial with Jackie Sobel at Wayne State University, doing a new trial in the current era to see if male partner treatment of women with recurrent BV significantly reduced rates of recurrent BV in the female partner. We recently published a study a couple months ago, EPUB. It just got published recently in the CID journal this month. And sadly, similar to the other male partner treatment trials in the 1980s and 1990s, again, here in this trial, we did not find a significant benefit of treating the male partners. The difference in this trial is that we treated the women and the men with the multi-dose metronidazole for 7-day regimen. We had an adequate power calculation. All the methods were much more rigorous. We enrolled the men face-to-face in this trial, handed them the medication, had them come back to clinic for follow-up, and monitored their adherence with pill bottle count. So we tried to overcome several of the limitations of the prior male partner treatment trials, but still the intervention did not work. In the conclusion section of the manuscript for this trial, we tried to talk about why we thought the trial still did not show a significant benefit of male partner treatment compared to placebo. And several of the things that we've been talking about is that a lot of the women that were enrolled in this trial had recurrent BV, which we know is a biofilm infection. And we think that they may have had such recurrent advanced BV biofilm disease. Treating them with oral metronidazole was not able to eradicate that. And they may have been so advanced in their disease that treating the male sexual partners did not help at all by that time. Also, there was some question about whether or not the men were adherent in this trial. We had a high actual reported adherence rate by the men. However, future trials should consider using like oral dose tignitazole, which we now have FDA approved. It wasn't FDA approved at the time this trial was started, so it was not used in this trial. So single dose metronidazole could take away the issues with adherence that they've had in this trial and other trials. And most importantly, it's not known if oral metronidazole can sufficiently eradicate BV-associated bacteria in the male penile microbiome. It's thought that perhaps topical antibiotic therapy could also help in conjunction with oral metronidazole. So some of our Australian colleagues, Catriona Bradshaw and her group in Melbourne, are doing another male partner treatment trial with combination male partner therapy with oral metronidazole and topical clindamycin. So it'll be really interesting to see the results of that trial when those are available. So I'm going to move on real quick for the next 10 minutes and talk about Trichomonas and vulvovaginal candidiasis, and then I will turn this over to Dr. Van Gerwen. With regards to the epidemiology of Trichomonas, we did have some new data published in 2018 in Clinical Infectious Diseases of national prevalence data for Trichomonas. This was the first time we have national prevalence data published that's based on a highly sensitive nucleic acid amplification test. And it's also the first time we have data published on the national prevalence of Trichomonas in men. So those were two unique aspects of the study. They found the prevalence in women was 1.8% and men was 0.5%. The male prevalence is lower than the female prevalence, and it's thought to be perhaps partially due to spontaneous resolution of trichomonas, which can occur in some men. It's not known how often, though, that occurs. Also, similar to BV and other sexually transmitted infections, there's a predominant racial disparity in African American women with regards to trichomonas. Their national prevalence is 8.9%, which is much higher than the overall prevalence of 1.8% in women. It's also important to note that these prevalence estimates exceed estimates of trichomonas burden in other high-income countries, such as the UK. There is some emerging data about the risk of trichomonas infection leading to an increased risk of cervical cancer. There has been a meta-analysis of published studies done in this area that was published in 2018, which found an increased odds ratio for a higher risk of cervical cancer in women who have trichomonas infection. So we have mentioned that in the updated trichomonas section of the guidelines. With regards to trichomonas diagnostics, we all know about wet mount. It's not very sensitive, 44 to 68% in the best of hands, although it is highly specific. Until nucleic acid amplification tests are available, culture has been the gold standard method of diagnosis. We don't use culture as often today. The main time we're using culture currently in vaginitis clinic here is to do drug susceptibility testing if we're worried about drug resistance in trichomonas. However, the sensitivity is also not great, as I have listed on this slide. There has been a large amount of trichomonas nucleic acid amplification tests that have come through the pipeline over the last decade. The first one is the Hologic Aptima NAT test. This was FDA approved only in women in 2011 now. The company did not seek studying men at the time, and they did not seek an indication to use that. So if you are using that test, it needs to be internally validated for use in men before giving patient results. I will say that our Jefferson County Department of Health here in Birmingham has been using this test since 2013 now in women and men coming to the clinic. The Alabama Department of Public Health did internally validate this test for men. So we have been giving patient results to women and men using this test. It is very highly sensitive and specific, can be used in symptomatic and asymptomatic women, but it is not a point of care or real-time test. So you have to wait to get your results. The BD Probe Tech NAT test was the second one to come out. Similar to Hologic, it's only FDA approved in women. BD does have a next generation test coming out though that is going to be FDA approved in women and men. So that's coming down the pipeline. The third one that came out is the Cepheid Gene Expert Trichomonas NAT test. This is an on-demand test that can be done at the point of care. If patients are willing to wait 40 to 60 minutes to get their test results. So it can be done. The machine to run it is smaller. You can put it on the bench top in a clinic, and you can get semi-quick test results on it. It is a little bit more expensive than the first two tests that I talked about. However, you get test results quicker, and it is FDA approved in both women and men on a variety of specimen types, including urine. There's two more that are coming down the pipeline, the Roche Cobas TVM Mycoplasma genitalium assay, which is recently FDA approved in women and men for urine. The big problem with this assay is that it's not recommended in the 2021 CDC STI treatment guidelines to screen people for Mycoplasma genitalium. So you have to be a little cognizant of what kind of patient you're ordering this test in. Right now, it's only recommended to test for Mycoplasma genitalium in men with persistent urethritis or women with persistent cervicitis, more complicated types of infections. So you may want to be a little mindful if you're going to be thinking about ordering this test for trichomonas, because you're also going to get an MG test result, and you need to know what you're going to do with it if you do that. And the last one in development that is currently FDA approved in the European Society in their national guidelines is the Abbott Alinity M assay, which gives you 4 pathogen test results for GC, CT, Trick, and MGent. That one is trying to get FDA approval right now in the United States, but currently doesn't have it yet. With regards to Trichomonas treatment, we had a big change in the Trichomonas section for the guidelines. Previously, multi-dose metronidazole was only recommended for HIV positive women. However, now in the new guidelines, multi-dose metronidazole is recommended for all women, HIV positive and HIV negative. And my next slide will tell you why. We have taken away the stat metronidazole dose for Trichomonas in women. However, it has not been taken away from men. So this is the first time we have CDC STD treatment guidelines that recommend discordant durations of therapy for women and men for an STI, which is kind of a frustrating, unique situation. And it's mainly because we have randomized controlled trial data in women, but we don't in men. My group and that with Patty Kissinger and Tulane, we have submitted a male treatment trial to NIH several times now. Sadly, it has not yet been funded, not due to lack of trying. We're just trying to convince NIH that Trichomonas is important in men. And I think that's been the main reason why they have not been exuberantly funding this trial recently. So until they fund that trial or someone funds that trial, we're going to have discordant treatment regimens in women and men for Trichomonas. So some of the data to support the change in women is a meta-analysis done by Patty Kissinger a couple of years ago, looking at prior trials of single-dose metronidazole versus multi-dose. And they found that multi-dose metronidazole was much more highly efficacious in curing Trichomonas compared to single dose. But we did do a head-to-head comparison here at UAB, also at LSU and Tulane in Louisiana, and the University of Mississippi Medical Center in Jackson. So we had a multi-center study that did a head-to-head comparison of single dose versus multi-dose metronidazole in HIV negative women. We did that trial a couple years ago. We enrolled over 680 women in this trial and looked at test of cure at 4 weeks after therapy by arm. And in this trial, we found that women in the single dose arm, 19% of those women were still positive for Trichomonas at their test of cure visit, compared to 11% of women in the 7-day multi-dose regimen. This was highly significantly different. So this is the main reason why the guidelines are changing to recommend multi-dose metronidazole for all women because of this. You still may be wondering, well, even in the multi-dose arm, we still had 11% of women, who are still having recurrent or persistent Trichomonas at test of cure. There could be several reasons why. All of these women were told to get their male sexual partners treated. We did follow up on whether or not that was done in the trial. We don't think that reinfection was a common cause of women failing in this trial. We did do Trichomonas genotype during this trial, which I didn't present that data. And the majority of women that had a positive test of cure culture had the same genotype that they had when they got in the trial, suggesting that they hadn't gotten a new strain of Trichomonas. But, we're still curious, why is 11% of women still having trick, even though they're getting multi-dose metronidazole, especially 19% in the single dose arm. So we wrote a hypothesis paper 2 years ago about why what do we think is going on? And we have 2 main hypotheses that we've come up just based on review of the literature and work with a pharmacy colleague of ours. We have not tested these hypotheses in any studies or clinical trials. However, we think that there could be BV-associated bacteria in the vaginal microbiome that may be causing metronidazole to inactivate. So especially if you give a single dose metronidazole and these bacteria are present, you're going to inactivate a portion of the metronidazole. If you give multi-dose, you're going to have more drug around in the space over time to hopefully eradicate more Trichomonas. Another hypothesis is that there may be accumulation of a metronidazole metabolite that may contribute to treatment success. So giving a longer dose of metronidazole may cause you to have more accumulation of this metabolite and be more likely to cure your Trichomonas infection. But, a lot of this still needs to be tested in studies. Finally, we just published a study a couple months ago about oral signatazole single dose for the treatment of Trichomonas. So I had talked to you all about it for use in BV, and it actually made it into the CDC guidelines for BV. However, this oral signatazole treatment trial for Trichomonas just got published. The guidelines were already written. It did not make it into the current guidelines, but oral signatazole has just been FDA approved for Trichomonas in women and men in this country. That happened on June 30th, so just 2 months ago. And so oral signatazole is going to be the only single dose medication we have right now for treatment of BV and Trichomonas in women. But remember, it does have that higher cost, as I mentioned earlier. So finally, I'm going to talk about vulvovaginal candidiasis. My colleague, Paul Nerajezi, an OBGYN up in Pittsburgh, wrote this section. I'm just going to talk about a few updates that he mentioned in the section. So we do have PCR testing for yeast with nucleic acid amplification tests. However, they're not as readily available as BV and Trichomonas are, and most of these tests are not FDA cleared. So he still is writing that yeast culture remains the gold standard for diagnosis in women of a fungal vaginitis. The treatment of uncomplicated VVC has not changed. So this treatment box is pretty much the same as that recommended in the 2015 CDC guidelines. There is a couple of updates for non-albicans vulvovaginal candidiasis, where they've reviewed several updated studies where they found that a longer duration of treatment between 7 to 14 days with a non-fluconazole azole regimen, if the non-albican species is fluconazole resistant, is recommended. And then if recurrence occurs, intravaginal boric acid in a gelatin capsule is recommended once daily for 2 to 3 weeks for these kinds of infections. There is a little bit of talk about a new oral medication available for treatment of uncomplicated vulvovaginal candidiasis, ibrexafungerp. This is in a totally different class than fluconazole and the azole drugs. It's the first in its class of glucan synthase inhibitor. It has great it has pretty decent oral bioavailability, less drug-drug interactions than fluconazole, longer half-life. It's a single dose. It was recently FDA approved for acute vulvovaginal candidiasis. However, it's not recommended in the guidelines because the guidelines were already written before this came out. We have used ibrexafungerp in one patient here in Vaginitis Clinic, and we actually have a second patient coming today that we may be using it in. So Dr. Van Gerwen is actually going to talk about it in just a second. Finally, there's some updated language on treatment of complicated and recurrent vulvovaginal candidiasis. I'm not going to read all this to you, but just refer to the CDC guidelines to get this new recommendation for that. And finally, the last thing I wanted to say, there is more and more data finding concern of pregnant women using oral fluconazole for vulvovaginal candidiasis having an increased risk of spontaneous abortion, cardiac septal closure defects, and other issues with their babies. So there is new language in the CDC guidelines about considering to avoid the use of oral fluconazole in pregnant women. So I'm going to turn it over to Dr. Van Gerwen. She's going to talk about some complex cases. Thank you all for letting me be here today.
So Olivia, before you move on, this is Bill Andrews. I have a question for you. Did the CDC and the 2021 guidelines address the issue of treatment of Trichomonas vaginalis among asymptomatic pregnant women?
Hi, that's the $1 million question.
It still is, apparently.
Yes.
Yes. We did talk about the Klebanoff study. I was not aware of any new clinical trials published since that. We actually had a vote. There was about 20 people in the room for the Trichomonas section. There was a discussion about whether or not to make multi-dose the recommended regimen in pregnant women. And people, basically, everybody voted to do it for all women. But
Okay.
there was no rigorous discussion about asymptomatic pregnant women, which is, it's a sad situation.
Well, the Klebanoff trial really wasn't the multi-dose 1-week therapy. It was sort of a therapy that nobody used. It was 2 grams and then 2 more grams 48 hours later, which was not recommended then or now. But that was what was used in the trial, both that and the sister BV trial.
Right.
So the question is, was the result that, for those of you who don't know, that this trial was prematurely stopped after about 650 patients on the way to a sample size of 2,000 by the Data Safety and Monitoring Committee. The primary outcome was preterm birth. And the reason it was prematurely stopped wasn't because of the observation that the rate of preterm birth was twice as high in the treatment versus the placebo group. It was because it was obvious that it wasn't going to show a positive result for the reduction of preterm birth. At any rate, it got prematurely stopped and reported.
Yeah, so the committee didn't really, they mainly talked about studies published from 2013 to 2019 at the time. And so, that study was briefly mentioned, but we didn't find any new studies published on that.
Thank you.
Great question. So thank you for Christina for that awesome overview of the guidelines. I'm going to talk about 2 cases that we've seen in our clinic since we started it up in June. So very new clinic, and we'll just talk through the cases, and then I have a little bit at the end about the clinic itself. So the first patient is a 20-year-old woman who is coming to us at the Vaginitis Clinic with a complaint of chronic vaginal discharge. So her story started in December of 2020 when she was diagnosed with Trichomoniasis. And then again, she came back to clinic and she was diagnosed in January of 2021 with Trichomoniasis a second time, as well as chlamydia. She got doxycycline and metronidazole. All was well for a little while. Then she presented back to care in February with a diagnosis of PID. So she was hospitalized and treated with cefotetan, doxycycline, and metronidazole. And following that, she basically, since she was discharged from the hospital, she said she started having a chunky, green, itchy discharge that was unbearable. So that started right after this hospitalization where she received IV antibiotics. She was seen a couple of times, it seems, outside of our system with this complaint, but she ended up being seen by an OB provider in April to talk about this discharge. And at that time, she was prescribed the typical recommended dose of fluconazole in addition to some nystatin. But her symptoms continued even after that appropriate regimen. So in June, she went back to care, had no relief at all, and a fungal culture was obtained that grew Candida albicans. There weren't any susceptibilities obtained for that particular isolate, but she was started on the next recommended fluconazole regimen that Christina mentioned from the guidelines. So the fluconazole 150 Q72 hours for 3 doses. And following that, she continued to have discharge. So her provider referred her to our clinic to see if there was something going on beyond your run-of-the-mill vulvovaginal candidiasis from albicans. So just a little bit about the patient. She was a sickle cell patient. She had PCOS, chronic pelvic pain. She kind of has a lot of chronic pain complaints as well. Based on her sexual history, she has 2 male sexual partners with which she has penile vaginal sex, intermittent condom use with those 2 partners, and her last sex was 2 weeks prior to presenting to us in clinic. And as I mentioned before, she's had a couple of different STIs, trich, chlamydia, and then PID. She does Depo-Provera for contraception, and she's not had any pregnancies. So when she came to us in clinic, these are representative photos. These aren't her actual photos. We saw on her exam with the speculum, this classic kind of copious, white, chunky cottage cheese type discharge. And she had a lot of erythema along the vaginal wall. So it was all very classic for yeast, which we already kind of knew based on the story that I just told you all. Her vaginal pH was 4, her wet mount showed no clue cells, but a lot of budding yeast and a little bit of pseudohyphae. And then when we did the KOH preparation, we saw a bunch of hyphae as well. Negative whiff tests, no other really notable findings on her wet mount. So these are just some representative photos of what we saw on microscopy. So I think the most important thing that we did for her was during her exam, we collected a fungal culture and we ended up having it sent over to the main hospital lab where they performed susceptibility testing. And I think, you know, Dr. Muzny mentioned this and hit on it. And I think it's extremely important that one of the reasons doing a fungal culture in these cases is so important is that fluconazole resistance happens, and it's common, more common than we think, I guess I should say. And I'll talk a little bit more about the details in that and the data in just a minute, but her culture did end up growing Candida albicans that was resistant to fluconazole. So this slide is the same one that Dr. Muzny showed earlier, showing that all of the recommended regimens to treat vulvovaginal candidiasis in uncomplicated situations are some variation on an azole. So what do we do with these patients like this woman who had albicans that was resistant to fluconazole, susceptible dose dependent to voriconazole? It's a very tough situation. And I'm going to talk a little bit about some of our options. And then as Dr. Muzny mentioned about ibrexafungerp, which is an exciting new medication. So talking a little bit about azole resistant vulvovaginal candidiasis in general, sometimes this is seen with non-albicans Candida species. Actually, it's more likely, or it makes more sense in that setting. You know, glabrata and krusei are two organisms that pretty typically have resistance to azoles. Krusei is actually always resistant to azoles. So if you have a patient who is failing your typical azole treatment with a candidiasis, you should suspect that they may have a species that is not albicans. But albicans is usually susceptible to azoles, and in vulvovaginal candidiasis, it's a bit of a different situation than other albicans infections, such as bacteremias, infections in other parts of the bodies. The resistance to azoles and Candida albicans is becoming more and more common. This is a little diagram from a study by Marcham et al. Jackie Sobel was one of the authors on that as well. And it just showed, Jackie Sobel. And it just shows that the fluconazole resistant vulvovaginitis cases in this kind of older study, the numbers of cases had been increasing over time, and that continues to happen. And the reason we think that is through excessive community exposure to fluconazole. So, you know, as we all know, a lot of times patients will treat themselves without any documented, you know, diagnosis of vulvovaginal candidiasis. They will treat themselves without even seeing a doctor sometimes. And so these repeated administered short courses of unconfirmed acute cases of VVC, in addition to these patients who have this recurrent problem and are always on fluconazole, kind of breeds resistance among the albicans when it otherwise might be susceptible. So it's an emerging problem. So when you're dealing with these patients, the kind of key tenets that Dr. Muzny and I have talked with Dr. Sobel about are twofold. So the first thing you have to do is really confirm that this is a problem that needs to be, you need to confirm exactly what you're dealing with. So is it a Candida species? What kind of species is it? And is there resistance? So doing a culture to confirm the diagnosis by identifying the organism and performing susceptibility testing in patients who continue to have symptoms is just absolutely essential. And then the next thing you want to do is say, is this what's causing their problem? You know, there may be Candida that's seen on a culture, but if someone has another explanation for their symptoms, you know, a non-infectious cause of vaginitis, such as, you know, like a estrogen deficient state leading to them having some kind of dermatologic problem, and those sorts of things. So establishing causation is important, since a lot of Candida just colonizes the skin and especially the vaginal area. So once you've done that, you want to determine your treatment recommendation. Well, as we just saw, there's not really a whole lot outside of the azole family that you can do. So from the literature, there's a couple of different things that people have tried that have been effective. The first thing is, depending on what the susceptibility, breakpoints are and what other things are reported on the susceptibility reports from your culture, itraconazole and ketoconazole could be options, though this is not often possible because cross resistance can happen, and you can see that on your susceptibility testing. Posaconazole and voriconazole theoretically are options, but these are broader spectrum and more prone to have side effects, so they're not routinely recommended either. Though if you're in a pickle, you can definitely consider them. Topical azoles, again, there's not a lot of efficacious. It's difficult to say how efficacious these would be in the setting of a resistant isolate, but they have been used successfully in some case studies, and certain ones, in particular miconazole and turconazole, have been reported to be effective in longer treatment courses. And then finally, as we mentioned, boric acid is something I think we're all familiar with for this problem. The regimen that has been successful for a lot of people in eradicating azole-resistant yeast infections in these women is 600 milligrams intravaginally at night for 14 days. And then beyond that, some women require a maintenance regimen to continue keeping their symptoms at bay. But I think one important thing I would say is that these things are just available on Amazon for people to get. So, it's difficult to know how high quality some of these suppositories that patients are giving themselves are. So I would encourage providers to discuss that with their patients. And there are compounding pharmacies that will create suppositories for you that can be formulated in a way that you're sure of exactly what product your patient is getting. A funny note on this, when I was doing an image search in Amazon for boric acid, like one of them was, I think it was roach poison that came up next to all these boric acid capsules. So it's crazy out there what these people can get on Amazon. So that's all. These recommendations come from this paper by Jack Sobel about the treatment of azole-resistant Candida. So as Dr. Muzny mentioned, ibrexafungerp is an exciting new medication that has a novel mode of activity against the fungal wall of Candida. And it works kind of similar to echinocandins, is my understanding, but it's displayed a broad range of activity against a lot of different Candida isolates, and it even works against some echinocandin resistant strains of Candida. So very exciting. And this is just a summary slide of some of the data that led to it being FDA approved in vulvovaginal candidiasis. So basically, this first study was an in vitro study of ibrexafungerp in treating vaginal yeast infections and blood yeast infections with albicans. And this study, which was from a group in Spain, found that there was high activity against the isolates, regardless of the susceptibility to azoles and regardless of whether it was from blood or vaginal source. So this was a very effective medication for Candida albicans in the vaginal specimens and the blood specimens, regardless of how resistant they were to azoles. And the vaginal isolates in this study, there were 5 out of the 72 who were fluconazole resistant. And then this DOVE trial was by Paul Niergezi's group, and it was a phase 2 trial where they basically looked to find the adequate dosing regimen for ibrexafungerp, but they compared several groups of dosing regimens of ibrexafungerp against 150 milligrams of fluconazole times 1, and they found the eradication rates in these cases to be similar between fluconazole and ibrexafungerp. So in June 2nd of 2021, very recently, Synexis, who makes this product, got an FDA approval to treat vaginal yeast infections with ibrexafungerp, and the trade name is Brexafem, which I think this is a cute little ad for it. And it's really, really amazing because it's the first approved drug that is in a novel class in more than 20 years for this sort of problem. So it's a big, big deal. We're not sure quite what the clinical implications will be yet, but I think it will provide a really good option for our people with azole-resistant vulvovaginal candidiasis. And it's also really wonderful because you just take these 4 tabs, you take 2 tabs in the morning and 2 tabs at night. So from a patient adherence standpoint, it's a really wonderful option. And as Dr. Muzny said, you know, we had this patient that I just presented who we actually ended up prescribing this to after we saw her and found her susceptibility results. We're going to see her in clinic this afternoon and see if her infection has resolved. And then we have another patient who also has azole-resistant Candida albicans vulvovaginal candidiasis that I just called the pharmacy to prescribe this to her as well. So in 3 clinic sessions, we've already had 2 patients with azole-resistant albicans. So I think this is something that we're going to see in use more and more frequently if we're checking cultures on these patients who don't respond to typical therapy. So I'll go real quick through this last case and then hopefully we'll have some time for questions. So this lady in this second case is a 39-year-old woman who has had persistent trichomoniasis. So her story began in August of 2020 when she was diagnosed with trich from a cervical swab nucleic acid amplification test, and she was treated with the recommended regimen of metronidazole 500 milligrams BID for 7 days. Well, she came back about a month later and had a test of cure performed on her urine, and her NAT was still positive. So she was given a second round of the 500 milligrams twice a day, 7-day dose of metronidazole. She ended up down the road. She continued to have symptoms intermittently throughout this time, but she had a new partner in May of the following year. When he developed NGU, he told her, and she was treated as a contact to trichomoniasis with the 1-time 2 milligram PO dose. She's not sure if her partner got treated. So at that time, for some reason, I'm not sure what the timing was in the outpatient setting, but she also had a NAT that was done that was also positive, confirming that the contact to trich actually did transmit the trich to her. So she was again sent to our clinic on the same day, the very first clinic day that we had. So she was a morbidly obese lady with sleep apnea. She was having penile vaginal sex with 1 male partner, but she's had a history of sex with women, and she's also had anal sex with people in the past, also inconsistent condom use. And as I mentioned before, she had a male partner who was also positive at some point during this whole time, and she was unsure if he had been treated. No other STIs, no pregnancies. So when she came to us, she had the typical clinical presentation of trichomoniasis with a greenish gray vaginal discharge. This is again a representative photo of her discharge. She had a spontaneous whiff test when we did the exam. And then this GIF shows what we saw under the microscope. So lots of little friends swimming around. And then she had a positive whiff test and a high pH. No hyphae were noted on her wet prep. So what we did in clinic was a Trichomonas in-pouch culture, which was run in Dr. Muzny's lab, and it came back positive. So as Dr. Muzny showed, this is what the Trichomonas in-pouch culture looks like. I think it's just so cool how you inoculate the media and then you put the media itself under the microscope to read it, to look for the trichomonads growing. So I put this picture here because I didn't realize that that's how you read that until I started doing work in this field. I just think it's very interesting. But Dr. Muzny's lab is able to conduct susceptibility testing against the 5-nitroimidazoles for Trichomonas isolates, and her isolate ended up being resistant to all 3 of these drugs. So very difficult situation. We're actually seeing her in clinic today as well to try and figure out what next steps are. So a couple of points on the management of treatment refractory trichomoniasis. Of course, history taking is just so essential in these cases. You have to make sure that this partner of a patient has been treated, because if they haven't, they could be reinfecting their patient. It's not that the trichomoniasis is refractory, it's that the partner is reinfecting the patient. So ensuring that is really important. Once you've done that, sending an isolate for susceptibility testing is the next step. And I have a slide coming up of how you can do that. So in the CDC guidelines, they have this link that I have on the bottom to the lab at the CDC that can do the susceptibility testing. And this is just a screenshot of where you go, like what it looks like when you go there. So you download a little form to fill out and you choose Trichomonas susceptibility. Again, usually we're doing NAT testing on patients. So if you suspect someone's refractory, getting a culture is an important step so that you can perform this sort of testing. But Dr. Muzny's lab also does susceptibility testing. So if you send patients to our clinic, we can do this sort of testing for them if you feel that they may need it. If you run into a situation where you are dealing with truly resistant trichomoniasis, there's not a lot of rigor behind what to use. It's mostly case reports and observational studies. We're actually doing a review paper right now with one of our medical students, reviewing the literature on how to treat resistant trichomoniasis, and it's just all over the board. But here are some regimens that are recommended. Mostly they're high dose 5-nitroimidazoles orally plus intravaginal, either tinidazole or paromomycin. And then of course, boric acid is also used. So we're just running short on time. So I'm going to just go ahead and talk a little bit about our clinic. So we're over here at UAB Highlands. We're actually sitting here right now in the boardroom downstairs. But UAB Highlands, as y'all know, is across campus, and we're located in the 5th floor of the building in the clinic side. And we have clinic right now one Friday a month in the afternoons, but because we have kind of a high volume at this time and need frequent follow-up for some of these patients, we are considering, either having clinic more frequently or interspersing follow-up appointments between that time as well. But this is a picture of our staff the first day we had our clinic, which was so exciting. So there's me and Dr. Muzny and our medical student and our wonderful nurses. And I have a few logistical slides on here, but since we're running short on time, I think we should go ahead and take some questions. So this is just how to order. And then here are a few studies that we're working on if y'all want to share them with your patients. So if y'all have any questions, please let us know. We'll both get in the frame now, and we have 1 minute.
Hey, this is Bill Andrews again. Have you had a significant number of patients who have what you believe to be chemical vaginitis, especially those that take a variety of these treatments that they can get online or in other places?
So we have had one patient that I saw, our patient who we're seeing this afternoon, who had, she actually does have resistant Candida, but I saw her one day right after she had done a long course of boric acid, and she had this wild discharge that I've never, it didn't look like any discharge I've ever seen before. She had nothing at all in her wet mount, and her fungal culture didn't grow. So I think she had some kind of irritant vaginal dermatitis from that. But we've not seen any referrals with that specific problem other than that one situation.
But we have just opened Dr. Andrews.
Yeah, today's our 3rd clinic.
Well, I've heard people who've treated vaginitis patients in their practice before give talks suggesting that they do encounter some patients that take a variety of these medications for identified infections, and after a prolonged period of time, they come to the conclusion that it may actually be a reaction to things that are in the medications themselves that are really a chemical response rather than the infection itself. Now, if that's true or not, I couldn't say, but I have heard that in more than one place. So I wondered if you'd encountered it.
Absolutely. I see 2 questions on here that I can answer real quick in the chat. So the cost of the ibrexafungerp medication, I just talked to the company today. So it just began being released in pharmacies. So it's kind of expensive if you do it just outright from a pharmacy. But if patients have commercial insurance, they can go to brexafem.com, and there's a copay card or a discount card or some kind of card that will make it $30 for patients to get at any pharmacy. So that's how much it costs. As far as squamative vaginitis, we typically consider it in our differential and are prepared to treat it, but it's not something that's necessarily in our wheelhouse at this time, but we anticipate that we'll see more and more of that as we go along, because it definitely, looks like yeast sometimes, looks like trick sometimes. So we've seen a little bit of it, yeah. Look at the other questions. Do you want to take?
Yeah, this is Todd Jenkins. Thank you for a great talk. This is more of a imploring your assistance. It's Dr. Boozer's first question is, getting the lab to do fungal culture susceptibilities has been quite a challenge. And so I can't think of when we would send a culture that we wouldn't want the susceptibility, because that's the whole reason we're sending it. So any help you guys can be in helping us lobby the lab to routinely run susceptibilities would be appreciated.
Hey, Dr. Jenkins, we talked to Sixto Leal about this. So he's gonna, he's on the lookout from us sending cultures. Even we have one of your patients coming today. We're definitely going to do a fungal culture with susceptibility testing. So I know Sixto is on board with us. I think it's just making sure to write that, like perhaps in the order comments, if you're ordering a fungal culture.
Yeah, the
So
last
they're
one,
aware of it.
the last one I ordered, when I wrote it in the comments, and then I called the lab to follow up on it, and they were like, well, you wrote it in the orders. Of course we're running the susceptibilities. So I think if you write in the comments that you're doing it, you definitely have a better chance, and then badgering the lab never hurts. So
yeah. I know we're running over time. We have our email addresses here. So if anybody wants to email us, we're more than happy to have an offline discussion. We're sort of learning ourselves as we go. I just spent a couple days with Jackie Sobel in Detroit this week at his vaginitis clinic. So we're just in a process of getting started here. So we appreciate the opportunity to talk to you all today.
yeah, we would love for y'all to send your patients to us, and we would also love to continue to work together with the OB-GYN group. There's so much overlap in what we all do. So we are open to collaboration, and we're excited to be a part of the fray with y'all.
Yeah, and we do have ongoing studies. We have BV and Trichomoniasis studies going on right now. We have the UAB Sexual Health Research Clinic that Jeannie Marazzo is the director of on UAB campus. So Dr. Van Gerwen and I have several studies going on there. And we also do studies at the Jefferson County Department of Health.
Mm-hmm.
So, we're more, every study is different. So if anybody's interested, just contact us, or if you think you may have a patient.
Yeah, this first flyer is for Dr. Muzny's BV pathogenesis study. And the second study is Letitia Alopre. She is in our division. She's doing a prep study in women over at the Shark Clinic. So these are both studies that y'all may see patients who would be eligible for. So consider us when you're seeing patients.
Yeah, Alicia's going to talk with us next month. So that'd be great.
Yeah,
Great.
yeah.
Thank you all.
All right,
Thank
y'all have a
you.
great day. Thanks for the
Beautiful.
opportunity. Bye-bye.